Think about the last time you got out of bed in the morning. Did you have to pause for a moment before you could stand up straight? Did you grab the nightstand or the wall to help yourself up? And then walking to the bathroom. Maybe the first few steps felt stiff, almost like your knees needed a minute to remember how to work. That feeling is familiar to millions of people your age, and most of them have been told the same thing. Rest it. Take the anti-inflammatory. Maybe try a knee brace. Come back if it gets worse. But here's what most people are never told. That stiffness, that instability, that grinding sensation when you go downstairs or stand up from a chair, a large part of what you are feeling is not coming from your knee joint. It is coming from the muscles around your knee. And when those muscles weaken, which happens naturally and quietly after the age of 50, your knee joint absorbs forces it was never designed to absorb alone. The cartilage takes the stress. The inflammation increases. The pain gets worse. And here's the part that most people get wrong. They either avoid movement completely because movement hurts, or they try intense workouts and squats and machines that overload an already inflamed joint and make things worse. Both of those responses accelerate the problem. What the research actually shows is something different, something simpler, something that takes about 10 to 12 minutes 3 times per week. And today I am going to walk you through exactly what that looks like. 4 specific exercises, each targeting one of the key muscle groups that protect your knee, explained in a way that is practical, safe, and grounded in the current clinical evidence. If you stay through to the end, I'm going to give you the complete weekly plan laid out simply so you know exactly what to do and when. No guesswork, no complicated equipment, just a clear plan. Welcome to Live Well Today. And if your knees have been holding you back from living the way you want to live, this video is for you. Before I show you the exercises, I need you to understand something about what is actually happening inside your knee as you get older. Because once you understand the mechanism, the exercises make complete sense. And you will follow them consistently instead of giving up after a week. Your knee is not a simple hinge. It is one of the most complex load-bearing joints in the human body. Every time you take a step, your knee absorbs a force equal to roughly 3 to 4 times your body weight. When you go upstairs, that number climbs to about 7 times your body weight. That is an enormous amount of stress passing through a relatively small joint with every single movement you make. Now, your knee is designed to handle that stress, but not alone. The muscles surrounding the knee, specifically the quadriceps in the front of the thigh, the hamstrings in the back, and the calves below, act as shock absorbers. They are the active protection system. When those muscles are strong, they absorb most of that force before it reaches the joint. The cartilage, the meniscus, the ligaments, they all experience much less stress when the surrounding muscles are working properly. But here is what happens after 50. Something called sarcopenia begins, which is the gradual, age-related loss of muscle mass and muscle strength. Research published in the Journal of Bone and Mineral Research estimates that most adults lose between 3 and 5% of their muscle mass per decade after the age of 30, and that rate accelerates significantly after 60. So by the time you are in your late 50s or 60s, the muscles around your knee may have already lost a meaningful portion of their protective capacity without you ever noticing, because it happened gradually. And when those muscles weaken, the knee joint has to absorb stress that the muscles should be handling. A study published in Diagnostics in 2023 found that quadriceps strength was directly and significantly correlated with postural stability and pain levels in people with knee osteoarthritis. Weaker quadriceps, more pain, more instability. Stronger quadriceps, less pain, more stability. The relationship is that clear. There is also a secondary problem that most people never hear about. When your knee hurts, your brain begins to reduce the signal it sends to the muscles around the knee. This is called arthrogenic muscle inhibition. Your nervous system actually suppresses muscle activation in response to joint pain. So the pain causes muscle weakness, and the muscle weakness causes more pain. It is a cycle that gets harder and harder to break the longer it continues. This is exactly why complete rest is almost never the right answer for knee pain after 50. When you stop moving, the muscles continue to weaken. The inhibition continues. The cycle accelerates. The research on this is increasingly clear. A 2024 Cochrane Systematic Review, which is the highest level of evidence we have in medical research, covering data from dozens of randomized controlled trials, concluded that exercise likely results in a meaningful improvement in pain and physical function in people with knee osteoarthritis. Not ice, not rest, exercise. But the type of exercise matters enormously. And that is exactly what I am going to show you now. Before we get to the exercises, I want to address something directly because I hear this from viewers constantly. You may have tried knee exercises before and had your pain get worse. Or your physical therapist told you to do squats, and every time you squat it feels like broken glass inside the joint. Or you saw a workout online and felt terrible for 3 days afterward. Here's what happened. When a knee is already inflamed, when the cartilage is already worn, when the joint is already irritated, loading it with heavy squats, lunges, or leg press machines places compression forces directly through the damaged surfaces. That increased compression can worsen inflammation, increase swelling, and delay recovery. The approach I am going to show you is different. These exercises target the muscles around the knee using controlled, low-impact movements. They build the protective muscle layer without compressing the joint in a way that causes additional irritation. And I want to be transparent with you about something. These are not cure exercises. Osteoarthritis is a structural change in the joint. It does not reverse with exercise alone. What exercise does is build a muscular support system around the joint that reduces how much stress the damaged surfaces have to absorb. You are not fixing the cartilage. You are protecting what remains. That distinction matters because people who understand it stick with these exercises long-term. And long-term consistency is everything here. A 2024 meta-analysis published in Science Direct covering 120 randomized controlled trials with over 10,000 participants found that resistance training significantly improved mobility, walking capacity, and knee extension strength in people with early to moderate knee osteoarthritis. The effect was meaningful and durable, but the benefits require consistency. They build over weeks and months, not overnight. One more thing before we start. If any exercise during this routine causes sharp pain, causes your knee to swell noticeably, or makes you feel that your knee is giving way or buckling, stop that exercise and speak with a physical therapist or your physician. These exercises are designed to be gentle, but every knee is different. Respect your body. All right, for exercises, let us go. Exercise number 1 is the seated knee extension. And I want you to pay close attention here because this looks extremely simple. Almost too simple, and I hear people dismiss it all the time. But this exercise is doing something that almost no other movement does as effectively for your knee. It is directly and specifically activating the quadriceps in a controlled way that does not compress the knee joint. Let me tell you why the quadriceps is the single most important muscle for your knee health. The quadriceps is the large muscle group running along the front of your thigh. It consists of 4 separate muscles that converge into the patellar tendon, which attaches to the top of your kneecap and then continues down as the patellar ligament to your shin. Every time you extend your leg, stand up from a chair, walk up a stair, or slow yourself down on a downhill slope, your quadriceps is doing the work. When the quadriceps is strong, it acts like a dynamic brace. It absorbs the shock of impact. It controls the speed and direction of knee movement. It reduces the lateral and compressive forces passing through the joint surface. When it is weak, all of those forces transfer directly into the cartilage, the meniscus, and the joint capsule. Research published in Osteoarthritis and Cartilage has shown that quadriceps weakness is one of the strongest predictors of functional decline in people with knee osteoarthritis. Here is how you perform the seated knee extension. Sit in a sturdy chair with your back supported and your feet flat on the floor. Make sure the chair is stable and not going to slide out from under you. Sit up reasonably tall, not rigid, just comfortably upright. Now, slowly lift your right foot off the floor and begin to straighten your leg out in front of you. Extend as far as you comfortably can. You do not need to force the last few degrees of extension. Go to where it feels comfortable. Now here is the important part. As you hold the leg extended, pull your toes back toward your face, just slightly, and at the same time consciously tighten the muscle along the front of your thigh. Really squeeze it. Try to focus your attention on feeling that contraction. Many people have lost some of the brain-to-muscle connection in this area due to arthrogenic inhibition, the pain-driven suppression I mentioned earlier. You are literally retraining that neural pathway every time you do this exercise. This is not just strengthening. This is also neurological re-education. A helpful mental cue is to imagine pressing the back of your knee downward, as if you were trying to push it toward the floor while the leg straightens. That cue tends to help people engage the quadriceps more fully. Hold the contraction for 2 to 3 seconds. Then slowly lower your foot back to the floor. Do not just drop it. Control the descent. That lowering phase, called the eccentric phase, is actually very important for building functional strength. Perform 3 sets of 8 to 12 repetitions on each leg. You can do both legs in an alternating pattern if you prefer, or complete all repetitions on one side before switching. Rest about 30 to 60 seconds between sets. Do not be fooled by how simple this feels. A systematic review published in 2024, compiled from data across multiple clinical trials, confirmed that quadriceps strengthening significantly reduces pain and improves physical function in people with knee osteoarthritis. The mechanism is well established. The evidence is strong, and the exercise requires no equipment, no gym, no special setup, just a chair. Exercise number 2 is the hamstring bridge, and this is the muscle group that most people with knee pain completely ignore, almost always to their detriment. The hamstrings are the group of 3 muscles running along the back of your thigh. Most people think of them as hip muscles or running muscles, but the hamstrings cross both the hip and the knee joint. They attach below the knee, and their role in knee health is critical. The hamstrings provide posterior stability to the knee, meaning they prevent the femur from sliding forward excessively on the tibia. They balance the pulling force of the quadriceps, and they absorb deceleration forces, meaning when you are slowing down or stopping a movement, the hamstrings are working hard to protect the joint from impact. A randomized controlled trial published in the Caspian Journal of Internal Medicine in 2023, which tested 4 different strengthening approaches in people with knee osteoarthritis, concluded that a combination of quadriceps and hamstring strengthening was the most effective intervention for reducing pain and morning stiffness. Not quadriceps alone, not hamstrings alone, both together. When the hamstrings are weak, the quadriceps end up doing all the work of stabilizing the knee from front to back. That imbalance leads to abnormal joint loading patterns. Think of it like a tent with guy wires on only one side. The structure is constantly being pulled out of alignment, and the poles at the joint bear more stress than they should. Here is how to do the hamstring bridge. Lie on the floor on your back. Place your feet flat on the seat of a sturdy chair or a low couch. Your knees should be at roughly a 90-degree angle, though the exact angle will depend on the height of the chair. If you have significant knee pain when bending to 90 degrees, raise the chair slightly or use a higher surface so your knees are at a more comfortable angle, perhaps 100 or 110 degrees. Before you lift, gently press your lower back into the floor. This activates your core and protects your spine. Now, press your heels downward into the chair surface. As you do this, begin lifting your hips off the floor. Rise slowly. At the top, tighten the muscles in the back of both thighs consciously. Squeeze them. Hold for 1 to 2 seconds at the top position. Then lower your hips slowly and with control back toward the floor. Touch down gently, then rise again. Perform 3 sets of 8 to 12 repetitions. If this feels too easy, you can increase the difficulty by placing your feet on a slightly higher surface, which increases the range of motion. If this exercise causes any sharp pain in your knee at any point in the movement, adjust your foot position to change the angle. Remember what I said about the nerve signal to your muscles. Many people with chronic knee pain have lost some of the brain-to-hamstring connection in addition to the quadriceps inhibition. When you do this exercise slowly and mindfully, focusing on feeling the contraction in the back of your thigh, you are rebuilding that connection. That is valuable. That is therapy. Exercise number 3 is the standing calf raise. And this is the one that surprises people most. Almost everyone I speak with who has knee pain has been told to work on their quadriceps. Some have been told to work on their hamstrings. Very few have ever been told to work on their calves for the sake of their knees. And I want to explain exactly why that is a significant omission. The calf muscles, primarily the gastrocnemius and soleus, do far more than flex your ankle. The gastrocnemius muscle actually crosses the knee joint. It attaches above the knee on the back of the femur. This means the calf is directly involved in controlling the flexion and extension of the knee during walking, stair climbing, and standing movements. When your calf is weak or excessively tight, it changes the mechanics of how your foot, ankle, and lower leg move. And because the entire lower extremity is a connected chain of biomechanical relationships, altered calf mechanics directly affect how forces travel up through the knee. Research in rehabilitation medicine has shown that people with weak or tight calves tend to walk with altered gait patterns that increase lateral stress on the knee joint. That increased lateral stress accelerates cartilage wear over time. There is also a balance and proprioception component. The calf muscles and the tendons attached to them contain sensory receptors called proprioceptors that constantly send information to your brain about where your body is in space. When calf strength and flexibility decline, so does this proprioceptive feedback. That means your balance worsens. And poor balance leads to compensatory movements that further overload the knee. Here is how to perform the calf raise. Stand about 2 to 3 feet from a wall. Place both hands lightly on the wall for support. Do not lean heavily on the wall. Let your hands be there primarily for safety and balance, not to carry your weight. Stand with your feet about hip-width apart, feet pointing straight forward. Now lean your body slightly forward from the ankles, just a few degrees, while keeping your heels on the floor. This forward lean increases the stretch through the calf and helps engage the full length of the muscle more effectively. From this position, slowly rise onto your toes as high as you comfortably can. Hold at the top for 1 second. Then lower your heels back to the floor slowly and with control. Do not let the heels drop quickly. That controlled lowering is important. It builds eccentric calf strength, which is the strength you need when you are walking downhill or absorbing the landing of each step. Perform 3 sets of 8 to 12 repetitions. The movement should feel smooth and controlled throughout. If you feel sharp pain in your Achilles tendon area, reduce your range of motion. If you feel balance problems, move closer to the wall and use more hand support. For those of you who have been told your pain is in the knee, but you also notice stiffness in your ankle or tightness in the back of your lower leg, this exercise is especially important for you. The two issues are frequently connected. Exercise number 4 is the sit-to-stand progression. And this is the exercise that ties everything together. I want you to think about how many times per day you stand up from a chair or sit back down. Every time you get up from the kitchen table, from your couch, from the toilet, from your car seat. Research suggests that healthy older adults perform this movement somewhere between 30 and 60 times per day. It is one of the most frequent functional movements in daily life. And for people with knee pain after 50, it is often one of the most painful and most feared movements of the day. Here is why this exercise belongs at the end of this routine. It integrates all 3 muscle groups we just trained. The quadriceps extend the knee as you stand. The hamstrings control the descent as you sit back down. The calves control your ankle and contribute to your balance during the transfer. And it adds something none of the previous exercises provided on their own: coordination and confidence. A study published in the journal Healthcare in 2025 specifically examined muscle activation patterns during sit-to-stand movements in people with arthritic knees and found that seat height and foot positioning significantly influence how much stress is placed on the knee joint during the movement. That research supports what physical therapists have observed clinically for years. Small adjustments in how you perform this movement can meaningfully reduce the load on the knee. There is also something that the research calls kinesiophobia, which is the fear of movement, fear of pain during movement. Studies have found that kinesiophobia, the anticipatory dread of moving your knee, can actually increase pain perception even before movement begins. And avoidance of sit-to-stand movements due to that fear is one of the most reliable predictors of functional decline in older adults with knee osteoarthritis. Every time you practice this movement safely and successfully, you are reducing that fear response. You are retraining your nervous system as much as your muscles. Here is how to perform the sit-to-stand progression. I am going to give you 2 levels. Level 1, the basic version. Sit toward the front third of a sturdy chair. Your feet should be flat on the floor, about hip-width apart, roughly under your knees or slightly behind them. Place your hands on your thighs or the armrests if you need support. Lean your chest slightly forward over your knees. This is the key alignment. Leaning forward shifts your center of mass over your base and dramatically reduces the force required to stand. Now slowly stand up, pushing through your feet as evenly as possible. Come to a full standing position. Pause for a moment. Then slowly and with control, lower yourself back down to the chair. Do not drop into the seat. Control the descent all the way down. Perform 10 repetitions of this basic version as your warm-up. Level 2, the progressive version. Now comes the progression that increases the challenge and builds more functional strength. Place your right foot slightly behind you, maybe 6 to 8 inches behind your left foot. Your left foot stays forward. Now perform the same sit-to-stand movement in this asymmetrical foot position. Because your right foot is behind, more of the loading shifts to your right leg during the standing phase. Hold at the top briefly, then lower back down slowly. Perform 10 repetitions with the right foot behind. Then switch and perform 10 repetitions with the left foot behind. Total for this exercise, 10 standard repetitions plus 10 per side in the staggered position, 30 repetitions total. If the staggered position causes significant pain, stay with the basic version for 2 to 3 weeks until your strength builds before attempting the progression. There is no shame in starting where you are. The goal is consistent, pain-free movement, not heroic discomfort. Alright, let me put this all together for you in a format you can actually use. The complete routine has 4 exercises. Exercise 1, seated knee extension, 3 sets of 8 to 12 repetitions per leg. Exercise 2, hamstring bridge, 3 sets of 8 to 12 repetitions. Exercise 3, standing calf raise, 3 sets of 8 to 12 repetitions. Exercise 4, sit to stand, 10 standard repetitions plus 10 per side staggered, for 30 total. The entire routine takes approximately 10 to 12 minutes when performed at a controlled pace with appropriate rest between sets. Do this routine 3 times per week. Not every day. Your muscles need 24 to 48 hours of recovery between sessions to rebuild and strengthen. 3 times per week with rest days between is the most evidence-supported frequency for this type of program in people with knee osteoarthritis. A good schedule might be Monday, Wednesday, and Friday, or Tuesday, Thursday, and Saturday. The specific days matter less than the consistency. If you miss a day, do not try to double up the next day. Just resume your regular schedule. For the first 2 weeks, I want you to stay at the lower end of the repetition range. 8 repetitions per set. Use this phase to learn the movements, focus on form, and pay attention to how your knee responds in the 24 hours after exercise. Some mild muscle soreness, the kind you feel in the thigh or calf rather than in the knee joint itself, is normal and expected. Joint swelling, joint pain that worsens in the 24 hours after exercise, or a feeling of the knee giving way are signals to pull back and speak with a healthcare professional. From week 3 onward, gradually increase toward 12 repetitions per set. This progressive overload is what drives continued improvement over time. What should you expect? Based on the Cochrane review I mentioned earlier, which pooled results from dozens of randomized trials, people with knee osteoarthritis who performed consistent exercise saw meaningful improvements in pain and physical function over the course of 6 to 12 weeks. Not 6 to 12 days. Weeks. Expect gradual improvement. Expect some days that feel harder than others. Expect your confidence in movement to grow. And measure your progress not just by how your knee feels on a given day, but by what you can do. Can you get up from the couch more easily? Can you walk an extra block? Can you climb the stairs without holding the railing? Those functional improvements are the real measure of success. A few practical points that make a meaningful difference. Before you begin the routine, spend 2 to 3 minutes walking slowly in place or around the room. Do not start cold. Your joint fluid, which is called synovial fluid, needs time to redistribute around the joint surfaces. Warming up the joint gently before loading it reduces irritation and makes the exercises more comfortable and effective. After the routine, if your knee feels warm or slightly swollen, a 10-minute application of ice wrapped in a thin cloth can help manage any mild post-exercise inflammation. Do not apply ice directly to skin. Keep it moving gently, maybe a short, slow walk around the room, before you sit down and rest. Allowing the joint to cool and stiffen immediately after exercise can create unnecessary discomfort. If you take pain medication, do not use it before exercise specifically to mask pain so you can push through. Pain during exercise is information. It is your knee telling you something important. Medicating before exercise removes that signal and increases the risk of overloading the joint. Also, footwear matters more than most people realize. Doing these exercises in socks on a slippery floor adds instability that can stress the knee. Wear supportive shoes with a non-slip sole, even when exercising at home. I want to talk about something that goes beyond pain for a moment, because I think this is the piece that gives people the motivation to actually continue with a program like this. The ability to get up and down from a chair on your own, to walk without holding onto walls, to climb stairs without someone assisting you. These are not small things. They represent your independence, your autonomy, your ability to remain in your own home, do your own shopping, care for your own life. Research published on sit-to-stand performance in older adults has shown that the ability to perform this movement easily and repeatedly is one of the strongest predictors of functional independence, fall risk, and quality of life as we age. Not your X-ray, not your MRI, how well you can stand up and sit down. And here is the encouraging part. That specific ability responds to training. It improves with these exercises. It is not fixed. It is not determined by your age or your diagnosis. The research is consistent on this. People who do the work of rebuilding the muscles around their knees regain function. They move better. They fall less. They stay independent longer. That is what these 4 exercises are really about. Not just reducing pain today, building the muscular foundation that keeps you moving confidently and independently for the next decade. Before I wrap up, I need to be clear about a few important boundaries. This routine is designed for people with chronic knee pain, stiffness, weakness, or early to moderate osteoarthritis who have already been evaluated by a physician and cleared for home exercise. If you have not had your knee evaluated by a doctor, if your pain is new or suddenly worsening, if you have experienced a fall or a trauma to the knee, if you have significant swelling that came on suddenly, please see a healthcare professional before starting any exercise program. These exercises are not appropriate as a first response to an acute injury. If you have had a total or partial knee replacement, the exercises I described today may need to be modified. Speak with your surgical team or physical therapist about which of these are appropriate for your specific situation and when. If you are currently working with a physical therapist, bring this routine to their attention. They may want to adjust the exercises, the sets and repetitions, or the progression based on their specific knowledge of your knee. This routine can absolutely be used alongside a formal physical therapy program. And if you try this routine consistently for 6 to 8 weeks and see no improvement whatsoever, or if your pain is consistently worsening with exercise despite following safe parameters, that is a signal to go back to your physician. There are situations where structural damage is severe enough that conservative exercise alone is insufficient, and a more specific medical intervention may be appropriate. Your knee pain is not inevitable. It is not simply what happens when you get older, and you just have to accept it. It is, in large part, a mechanical problem. And mechanical problems respond to mechanical solutions. The muscles around your knee weakened. They weakened gradually, quietly, without announcing themselves. And your knee began absorbing forces that it was never meant to absorb alone. The result was pain, stiffness, instability, and a fear of movement that made everything worse. For exercises, 3 times per week, 10 to 12 minutes per session. Rebuild the quadriceps. Rebalance with the hamstrings. Restore calf control and proprioception. Retrain the sit-to-stand movement that represents your functional independence. That is the plan. It is based on clinical evidence. It is practical. It is safe when followed with appropriate attention to your own body. And it works for people who do it consistently over weeks and months. I want to hear from you. Drop a comment below and tell me which of these 4 exercises you are going to start with today. Or tell me how long your knees have been bothering you. I read every comment and I respond to as many as I can, because understanding what you are going through helps me make the content on this channel more useful for you. If this video gave you something useful, subscribe to Live Well Today and turn on notifications. We publish new videos every week on joint health, mobility, nutrition, and the practical strategies that help people your age live better and move more confidently. Take care of those knees. I will see you in the next video.